How do you want to take further history from this patient, Dr. Maria?
Okay, thank you, Dr. Hissam. After greeting Diana, introducing myself and checking stability, I will assure about confidentiality and offer her to lay down to be more comfortable. Then I want to ask open-ended questions regarding this palpitation. I want to know what do you mean by palpitation and when it started sudden or gradual, constant or on and off, any specific timing pattern and how it progressed. Is it the first time or there are previous episodes? If previous episodes, I want to know if she visited any GP or had any investigations, especially echo or prescribed any medication. And I want to know regarding its character. I will ask Diana to tap on the table to understand its character. Then I want to know what about rest physical activity, herbizartans that the patient use, makes the condition better or worse or not. And regarding triggers, any trauma, contact with sick person, recent infection, skipped meal, sleep deprivation, chance of dehydration, any stressful conditions, also after normalization, any chance of recreational drug or smoking, and also is it compatible with the anniversary of her husband or not? And I want to know how this condition affect her daily routine, social life, mood, sleep, appetite, how she cope with it. And also for associated symptoms, I want to know if there is any numbness, tingling, slurred speech or blurred vision or asymmetry, any fever, chills, rashes, any lumps or bumps all over the body or unexplained weight loss, any change in weather preference, constipation or diarrhea or palpitation, and also any cough, noisy breathing, any shortness of breath, lightheadedness, easy fatigue, bleeding from any other part of the body. And also I want to know if there is any shortness of breath, chest pain, also if yes, it's radiation, and any nausea, vomiting, cold, clamminess, any leg swelling, calf tenderness, recent travel or immobilization or major surgery, any flank pain, dysuria or hematuria, any polyuria, polydipsia, polyphagia. Also, regarding woman health after normalization, I want to know if there is any chance of vaginal bleeding. And also for herbizartans that the patient use, I want to know she use it regularly or not, any chance of forgetfulness, and when was the last visit for her GP, and also what was the last measure. And also I want to know if she is driving or not. And regarding a home situation, also I want to know she can do her daily chores or not, receive support or not, any chance of fall, any slippery surface, inappropriate light or many stairs. Also regarding her sleep quantity and quality, any snoring, and also regarding her mood, if everything is okay, or any chance of anhedonia, any stressful condition. And then I want to ask regarding 7 rules of elderly, any problem with
Dr.
here?
Maria, I'm sorry for interrupting you. So she states that this palpitation has been started from a few months ago, but got worse from 2 days ago, okay? And she had some shortness of breath while walking. It has been from a few months ago too. What is your focus physical examination?
Okay, thank you. First, I will follow standard protocol, explain all steps to Diana, gain consent. For general appearance, I need to check for any facial asymmetry, any pallor, dehydration, any protective posture, and also for vital signs, I need to check blood pressure in 2 position and the pulse for rate, rhythm, and volume. My focus physical examination will be complete cardiovascular examination and as relevant neurological examination, and thyroid and conjunctiva for pallor. For office test, I need blood sugar level, ECG, and urine dipstick, and full risk assessment with some tests like timed up and go and sit to stand test, and geriatric depression scale, and mini mental state examination. For cardiovascular examination, I will start from hand for blood pressure in 2 position in both hands and compare, and pulse for rate, rhythm, volume in both hands and compare. Then inspection of chest wall for any visible apex speed, any sign of trauma rash process, then palpation for any displaced apex speed, any thrills or heave, then auscultation for S1, S2, galoprism, all heart valves in their anatomical position, and then I will check lower extremities for any edema or varicose veins or any skin changes. Then I will go to neurological examination. I will check upper and lower limbs for tone, power, reflex, sensation, coordination, and also I will examine all 12 cranial nerves and assess gait and balance by specific test as tandem gait or Romberg test. Then
Thank you. So the blood pressure is 120/80. You have found some basal crackle in lung, and all other examinations are unremarkable. You have the ECG in the chat box. Can you please interpret the ECG and tell me what is your diagnosis?
Okay. Okay, first of all, I need to check name and date to make sure it belongs to my patient. As I can see, it's a 12 lead, well-calibrated ECG. For rhythm, it seems irregular, and for rate, as it is irregular, I can calculate it by multiplying number of QRS and long lead by 6. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9. 9%. So it's 54. So it's 54, and I can't appreciate B wave, and also I can't appreciate any ST segment changes. QRS seems normal. And yes, my provisional diagnosis is atrial fibrillation, but I need to double check it with my supervisor.
Okay, very nice. Thank you. So imagine the heart rate is 84, okay? Imagine the heart is 84. So what is your management for this case?
Imagine it's 84?
Yeah, it is 84. It is 84 all the time in the exams. So imagine it is 84.
Okay. You need management, doctor?
Yes, management. Let's go with management.
Okay, thank you. First of all, as the patient has basal crackles on examination and shortness of breath, so I will consider the condition as emergency case. I will transfer the patient immediately to treatment room on a wheelchair and ask supervisor and the practice nurse to join me for primary survey based on GRS ABCDE. Meanwhile, I will explain to Diana about her condition and confirm diagnosis with my supervisor. In this regard, we will secure two IV lines, take blood sample, and also give oxygen if needed. And I explained to her that it seems there is some irregularity in your heart rate, and also your condition is not stable, so we need to transfer you to hospital for further assessment and management. And while my supervisor is beside the patient, I will call ED registrar based on SPA protocol, and we will closely monitor the patient until paramedics arrive, and then I will ask the patient to come to me after discharge.
Okay, very nice. So what do you do in your follow-up session? Imagine the patient is stable in the follow-up session. What would you do in the follow-up session?
Okay, first I will thank Diana for coming today, and I will share all findings with supervisor, and I will also check discharge letter for exact diagnosis and what was done, and also any recommendation for me and the medication prescribed for the patient. I will also need to check her physical focused history and examination, and also I need to repeat ECG again. And also I will, based on ECG, I will continue my management. I will start with non-pharmacological. I will emphasize on lifestyle modification based on SNAP protocol. I will advise her to be hydrated, avoid skipped meals, sleep deprivation, limit caffeine intake. Also, I will, regarding pharmacological management, I will divide it into rate, rhythm, and anticoagulant and underlying condition. But first, I need to check if medications was prescribed for her. If the patient was prescribed, can I know what medication was prescribed for the patient or no?
No need. So only who are the specialties that you want to be involved in this patient? Just mention them, and the case will be finished.
Okay, then I will review her medications and also check for any side effects. And also I will check if she was prescribed beta blockers and also anticoagulant. and check for any side effects from it. Then I will activate a GB management plan and arrange team care arrangement and social worker and occupational therapist, and also arrange a family meeting if she agree. I will educate her about red flags, which are any CNS effects as numbness, tingling, asymmetry, or cardiac like shortness of breath, or worsening of the condition again, or chest pain, or any bleeding.
It is more than 10 minutes now, but if you want to continue, continue.
Okay, then I will explain to her regarding, I will arrange a review session and educate her regarding sleep and relaxation techniques. Also, I will emphasize on keeping vaccinations updated. That's all.
Very nice. Okay, doctor. Very, very nice. Thank you.
Thank you.
Okay, Dr. Mar, you were great, I believe. A few points, just a few points. First of all, I mentioned this in every sessions of mine, that we have the blessing of having a great channel, that the recalls are in that channel, and they are mostly constant. The recalls wouldn't change. If you check the recalls, you can see always the heart rate is 84. They're gonna go from interpretation of ECG, go to the management without asking about any investigation or differential diagnosis. And you can see that some recallers say that what are the specialties that you want to involve, because they haven't mentioned them in their management. So the panel will say, okay, who are the specialties we want to involve in this patient? Seemingly they are looking for specialties that should be involved in this patient. So look at the recalls so you wouldn't be surprised, and you're gonna have your structured, very, very good, that's docked.
So sorry, I didn't see this recall. So sorry.
Yeah, no worries. Just look at the channel, look at the NOT channel, and the recalls are there. Just search AF, and you would see all the recalls of AF, like 20 of them. You can see how similar they are. Just very, very slight differences between the different candidates that's recall the case. So in the history taking, so just a few points, but you're gonna be, I would say you're gonna be passed, you're gonna be suitable for this case. Besides a little feedback in the management part, because you got out of time. You have mentioned all the things. I believe that this is only my idea. I'm not saying that my idea is right, okay? But I believe that leaving alone of Diana is very important, because she leaves alone, and it is an important matter to be addressed. You mentioned that social worker should be involved. I wanted a little more emphasize on that part. That would be the best. But besides of this little feedback here, I believe that you would be suitable for this case. You were great in the history taking and triggers of the palpitation. You were more than great. Again, in the history taking, you just overlook the leaving alone part. I believe it is very important. The leaving alone thing is very important. I have recently seen this Czech magazine that was all about, like, 5 cases about leaving alone, how leaving alone is important for GPs there. So just have it in your mind. Physical examination was more than great. Interpretation was, again, great, and your management was really, really safe and nice, and good explanation. Everything was good. So I believe you would be suitable. Just look at the recalls, so you know that in this case you would need to go to the specialties at the end of the case. You would need to address the leaving alone thing and such things. And I believe you were great, and you are completely passed successfully this case. Okay, so
I was confused, surprised by the last part of the question in management after discharge, so I was not ready for it. So sorry.
Yeah. Yes, in the classes there is a little change. Little by little cases change a little bit, but if you look at the channel, you would see that recalls are really, really constant. They wouldn't change. And this is how AF came in the exam, I believe. I see all of the AF cases, and besides of one time that the heart rate was 54, all the time heart rate is 84, and all the time they are looking for the specialties that should be involved. And you can't say I want to transfer the patient to the hospital. You even can overlook it. You can just omit this part to transfer the patient to the hospital. So let's recap the case very quickly for other peers. So yes, so Diana 77 lives alone and palpitation. These two are very important. So there is an initiation part. As you know, we are not going to talk about it. Whatever you're happy with. In my case, if I know that they ask what further history do you want to take, but in my real practice, I would take an ECG from a patient with palpitation, especially if they say I have sudden palpitation, sudden onset palpitation, emerge suddenly and disappear suddenly. I had it in my structure. I haven't come in my exam, so if it came and I would say that, I might have a feedback. It might be a bad thing to say, but I would say it. What I would say, if my patient experiencing palpitation right away, and it has short episodes, I like to take an ECG firstly. This would be in my initiation part, and then asking open-ended question, as you said, then exploring the palpitation. You said it very nice. I'm not going to repeat it. Yeah, but you know, they say if the patient can feel a skipped beat or extra beat, you can say that. Do you feel any skipped beat or extra beat? Do you feel it's irregular or irregular, and such things? And again, about triggers, you were very complete. And the effect, you were great. The effect on the daily routine, social life, especially because it seems that it is a little bit chronic. And then the associated symptoms. In associated symptoms, I thought that maybe hypoglycemia attack and myocardial infarction symptoms, these two are a little more important than others. So I separate them from the other associated symptoms and tell them with more emphasis at the first part of associated symptoms, then going for other parts of associated symptoms. You know, I'm saying like any syncope, any chest pain, cold sweating, and shortness of breath with this palpitation or not, you know, such things. And then going, any fever, chills, any like TIA symptoms, you can ask about them, why not? Any lump or bump anywhere on the body, night sweat, you can ask about that, why not? Hyperthyroidism symptom for sure, diabetes and everything else. So this was associated symptoms. Then in the end part of this case, so you were going like women health, then psychosocial history, then 7 results elderly. The most important thing is that you should have this general context, this big observation of big context of general practice. You can see that everything is not about this palpitation. You can see that the patient is living alone. You can see she is elderly, so locomotion, visual, I do not know the symptoms of elderly, and everything else should be addressed. You can see that the patient has hypertension. Is it under control or not? If the patient is adhered to the medication or not. Yeah. So the most important part in the end part of this history of this case is to somehow cover them. It does not matter how is your structure. Do you want to go from women health, then psychosocial history, then 7 results elderly, anything that you want to do. It is not important as far as you are mentioning the important points. So I believe the most important one is to address the hypertension and the medication that the patient use, to address the 7 rules of elderly, mostly forgetfulness, locomotion of the patients, and incontinency, and then the psychosocial history part, which the most important part is the living alone part of the patient. So if the home is safe, who are visiting her, who is the main supporter for her, and such things. So that would be the history thing of this case. You would cover everything, I believe. And you have covered it, Marianne. You were great. And I just said it a little shortly. So in the physical examination, you were more than great. in my structure, it was not like yours. You were so much more complete and so much more greater than mine. So I want to just omit this part. Yeah, you know, in general appearance, you should the most important thing in physical examination part, I mentioned it in every sessions of mine that in my physical examinations, I didn't have the chance to go for focused physical examination in almost none of my cases. I didn't have the time because I was like, you know, mumbling and, you know, losing the time by saying some irrelevant things. Not saying irrelevant, just some like clinical reasonings. I would say, yeah, I want to check the geriatric depression scale because of that. I want to check your MMSE because the patient is elderly. Because of these things, I haven't had the time to go for the focused examinations mostly to explain like what is the cardiovascular examination. If this case would come in my exam, I wouldn't have the time to say that. So I believe that this first part that you are going through general appearance, then vital signs, then what is your focused physical exam, what is real relevant, and what are your office tests. This part is the part that they are looking for. This part is the most important part for them. And they are not looking for you know, saying the physical examinations like you are a medical student. They are mostly not looking for that. I assure you that one. So that was it. So this was the physical examination. And then the interpretation of ECG. Again, you were great. Yeah, name, date, calibration, and then rhythm. You have seen that it is irregular, and then maybe it's good to mention that there is no STT changes. These things are not important that much. You mentioned that it is irregular rhythm and important and mentioned important points, so it was completely great. So for management of this case, my management didn't have, you know, in my structure, I haven't had the transfer to the emergency room part. I haven't that part, yeah. So I was like, okay, as there is no, sorry.
Sorry, Dr. Ihsan, you mentioned the patient has basal crackles and shortness of breath. Isn't an emergency and the patient unstable?
You know, you are a general practitioner. I am a general practitioner. Both of us have good, you know, knowledge, have our own clinical judgments. You know, the most important thing in this exam is that you understand that you are really, really great, and whatever you are saying, as far as you are completely safe, is correct, and whatever I'm saying in the manner of knowledge, what I'm saying is completely right. So we can discuss it, like going to detail of, okay, the patient has shortness of breath, so this was an AF with congestive heart failure. It can be like an emergency condition, or in such condition, or because the blood pressure is normal, it is not an unstable patient. So the most important thing is that you're gonna be safe. This is the part that they're looking for. Like I know that in one day they have this fall BPPV case, so two candidates, and one of them sent the patient to the hospital. The other didn't send the patient to the hospital, as it wouldn't need any need to transfer, as a matter of fact, to the hospital, and managed outpatiently. And both of them passed the exam. I know this happened. So do not be strict. Everybody have their own knowledge thing. So in the manner of knowledge, we are all great. And I'm not going to say, yeah, no, because I have passed the exam, I believe that this patient is not stable. Yeah, if you think this patient is unstable, and you need the patient to transfer to the hospital, do it. It's completely right. I thought that this patient is stable, as the patient has had this shortness of breath from 3 months ago. It is an exertional shortness of breath. So the patient had this CHF from a long time ago, maybe. So I thought there isn't any acute condition happening right now. There isn't any acute condition happening, so I thought, yeah, maybe the patient don't need to be transferred to the hospital. But if, for example, the heart rate was like more than 150, you know that the patient should be transferred to the hospital. In that case, we all know that in AF cases, if the heart rate is more than 150, the patient should be transferred to the hospital. It is not our job to manage the patient in the treatment room. Or if the patients had the heart rate of less than 60, the patient should be transferred to the hospital, yeah? Especially if the patient had this, pulmonary edema symptoms. So some things are net, some things are not negotiable. We know which one are them, but mostly they are going on a border. It is either the decisions are right. I believe this is the case in the PESCI. So I have talked a lot. So yes, in the initiation part of the management, I thought the patient is stable, and I mentioned that with consulting with my supervisor, I want to consider outpatient management for her. I show that I'm safe. I'm not going to say, yeah, this patient is completely outpatient and such things. I'm going to say, after checking safety netting, like in a pneumonia case, in a pneumonia case, a cattle farmer case, you should say that I should check safety netting and the distance of the patient to the hospital and such things. In this case, too, you should mention that I would check. If you want to consider the patient outpatiently, you should show that you are safe. You would check the safety netting, you would consult with your supervisor, and then consider the patient to consider managing the patient outpatiently. Yeah, and then there is non-pharmacologic management, SNAP protocol, as you said, very, very great. And then general advices like avoiding triggers, stresses, caffeine, such things, and doing yoga, mindfulness, everything else. You were great. I have my pharmacologic management adopting from Dr. Musayeb, if you know Dr. Musayeb, who was a really great tutor. He's not tutoring anymore, but he had this really great structure. I used this. It is really, really great for pharmacology management. He said that there are 4 parts of management of AF in the manner of pharmacology management. There is rhythm control, rate control, anticoagulation, and treatment of underlying causes of atrial fibrillation. So for rhythm control, what would we do? And nothing, just transferring the patient to referring the patient to the cardiologist. They might decide want to do cardioversion or pharmacologic management of rhythm control of AF. For rate control, if the heart rate is 80, more than 60, we can consider prescribing beta blocker. As I am not completely dominant on this part, wherever I'm not that much dominant, I would say I'm going to check it with my supervisor. If you are sure that the patient with heart rate of 84 can take beta blocker, you are like some of us are really, really better in cardiology field. If you are somehow sure and you have read all of the guidelines of it, don't say that I want to consult with my supervisor. Like I have had this. I'm relatively good in orthopedics, for example. In my examination for a fracture case, the scaphoid fracture, I haven't mentioned anything about my supervisor. I did all the things myself. I were completely confident. I haven't had any feedback on that. But for example, in another case, I mentioned my supervisor a lot of times because I wasn't that much confident. Anyway, so regarding anticoagulation, you should consider chats. Anticoagulation, you haven't mentioned anything about anticoagulation. I believe that they are not looking for this. Yeah, and you wouldn't have a feedback on this part. You haven't mentioned anything about anticoagulation. They say, okay, she didn't say anything about anticoagulation, so he failed this case. This case is not about that. If you think about it, you can see that they are looking for some more general things, like, as I said, the leaving alone thing, the explanation of the condition to the patient, such things. Considering the CHATSVA and the bleeding risk, like there is HAS-BLED stratification risk stratification, you can consider starting a DOAC, like direct acting anticoagulations like apixaban, and change it to warfarin if echocardiography was completely normal. And then underlying causes, you know what are underlying causes of AF? Because I wasn't that much dominant on this, I have extracted, so I want to share it in the group. Reversible causes of AF. I believe we as GPs should know this. So you should know. You should have a thought on what are secondary causes of atrial fibrillation. So you should do some like checking the hyperthyroidism, checking some electrolytes and iron and such things. And if the condition is reversible, you should manage it accordingly. Besides that, in the end part of the management of this case, the thing that should be addressed, again, I mentioned it a lot, is the leaving alone thing. Like managing the aged care, involving the aged care assessment team, social worker for Meals on Wheels, and maybe a geriatrician can be helpful too here, and occupational therapist for sure, as you said, and other things. And GP management plan is very important, I believe, in this case. You should mention that, as you said. So this was mostly it. I have written something here that I want to read it for you too. So there are 5 domains of general practice. This is the end part of the case. So domain 1 is communication skill. How do you want to pass the domain 1 of general practice in this case? The patient lives alone, so you should have empathy for her. Domain 2, in this case, is about knowledge. In domain 2, the thing that you should do is be safe. Just be safe, because there are if you overlook asking about myocardial infarction in the history taking, you would like have feedback. You see, they say, okay, he completely forgot about such an important symptom, myocardial infarction symptom. So be safe. And this is the thing about domain 2. In domain 3, it is about population health and context of general practice. The thing in this part is that in the history taking, you address the elderly health check, and in the management, again, the living alone thing. There is no part. Domain 4 is professionalism. In this case, there is no professionalism needed to be addressed. But in domain 5, it's about the domain 5 is legalization, organizational issues, such things. In this part, you should mention about care plans. GP management plans is for domain 5. That was it. I believe I thought that it might be helpful to somehow look at the case from this point of view, and we have finished now. Okay, what are the questions? Yeah. So I think Shonda Price is working, but not in rest, can consider outpatient. Yeah, Sahar mentioned, yes, a great point, very nice. If we manage the patient as outpatient, what kind of referral for cardiologist should we give? Acute and non-acute? Dr. Rashid. Dr. Rashid, whatever you say is right. Again, this is the thing that most of the guys do not know about PESCI. They are looking for these little points. If there is a thing that there are more than one answers between the peers in your group, you can be sure that all of answers are right. So if you say non-acute, they're not gonna fail you. If you say acute, they're not gonna fail you. I believe it is acute. Yes, I believe it would be an acute referral, an acute like in less than 24 hours for sure. It is an urgent less than 24-hour referral. But if you say non-acute, because some doctor might say, some come here and say, no, the patient had this palpitation from 3 months ago. Why should we have an acute referral? And they everybody have their own guidelines,